go. So I am privileged to be here today with Dr. Dowin Boatright, who's a assistant professor of emergency medicine at Yale University. And hey, Dowin, do you know why you're on? Why I'm interviewing you today?
No idea.
Well, the main reason I'm interviewing you is because you're a friend of mine, and you know, I respect your ideas, and I get the opportunity to talk to you about things that matter to you, and I get to hear sort of your perspective on stuff, and so that's the reason you're on.
Well, Jeff, I'm glad we get to talk. I missed the opportunity to hang out with you as much as we did, especially when I was a resident. You know, I still remember the time we first had breakfast together. It was, do you remember, I don't remember the name of the pancake place.
Snooze. We went to Snooze that first time.
Yeah, that was amazing. Yeah. That was, I think that was one of the like key moments in my residency.
Well, I'm glad I could be a part of it. That's awesome. So the first standard question that I have is tell me about how you got to where you are now. And that means from wherever you want to start, whether that's, you know, at birth or whether you want to start from med school, wherever you want to go.
Well, you know, what I would say, Jeff, I would actually start right at that breakfast. So, you know, at that point, I think I did have interest in research, but the research was definitely more related to trauma and probably more of what people would consider to be traditional research in academic medicine. And along that time as well, I was interested in diversity, but I wasn't actively engaged in anything. And I think at that breakfast, we started talking about the possibility of having diversity initiatives at Denver Health and in the residency program. And I think my career really started moving in that direction in a very significant way because of that breakfast. So I think a lot of it was your mentorship.
Oh, well, flattery will get you everywhere. That's the first thing. I think that it was pretty clear to everybody that had met you that you were destined for phenomenal things, regardless of who it was that you interacted with. But I did want to sort of ask you a little bit about some of the barriers that you've had in your career and what you think it was that helped you get to where you are and what you think has held you back.
Yeah, so focusing on thinking about barriers, you know, I don't know. I think there are a couple of things I kind of think about initially, Jeff. So I think one, I think having a strong network of mentors and just a strong social network, I think is one key thing. And I think having that group of people that will believe in you regardless, I think is a key factor as well. So, you know, I initially started off in ear, nose, and throat as a resident, and I transferred out of that after my second year because I found out I had very little depth perception, and I actually wasn't able to operate under the microscope. And, you know, for a while, you know, when I realized that and then making that transition, you know, I think that was a pretty lonely and isolating time. And I think I did have the benefit of having quite a bit of support from the emergency medicine department, both from Maria Moriera, who also, you know, had transferred from surgery when she was a resident. So I think she had experience with people making a transition and was willing to support me there. And I also had a lot of support during that time of transition from Von Brown, who I had interacted with before, and he gave me a lot of research opportunities when I was making the transition into residency, and also during my intern and second year as a resident as well. So I think having that support system, especially when you experience obstacles, is important, and I think was integral for me to have a successful career. And I think one problem is I think sometimes it's difficult in general to have that degree of a support system. And then also I think for physicians or medical students of color, I think that degree of support system and social network can be especially limiting. So I think that's, you know, having that was significant for me in terms of being able to recover in terms of my career. And I think that would be something I'd advocate for institutions developing to support physicians of color, and then also as individuals, as physicians of color, or anyone from a marginalized group, to very actively try to develop their own extended network of mentors and a peer support system.
That's awesome. I like that answer. So, you know, and I guess I should say this for anybody that's watching this, if anybody watches this, as I said before, this is all for me. So, you know, but I think that it's really interesting sort of watching what you've done in your career. Because I mean, from a diversity perspective, we sort of started stuff at Denver Health, and you have blossomed. For those of you who don't know, Dowin is one of probably the preeminent diversity researchers in medicine, in the world, honestly. He was the main author for the paper on AOA and the disparities in terms of how AOA processes things. And to be honest, based on that paper, the AOA has dramatically changed how they're doing their selection, and they're leaving it up to each school. And I mean, that's an enormous change that I think is entirely secondary to you. And so I think realizing how much of an impact you've had based on, what you've done. And I guess one of the questions that I had was, how did you go from sort of this small, like local, making a difference in a small area to making a difference? Honestly, I mean, this is going to affect medicine across the board.
Well, Jeff, you're going to make me blush now, but I would honestly say, again, I attribute a lot of that to your mentorship, Jeff. So I think I remember when I was finishing or nearing the end of residency, I was thinking about applying for a research fellowship. And one of them was, of course, was the Robert Wood Johnson Foundation Clinical Scholars Program. And I met with you to talk about applying, and I was like, Jeff, should I do this? And your response was, if you can do any research program you want, and that'll give you, extended reach. But he's like, if you do the Robert Wood Johnson Clinical Scholars Program, your reach will be infinite. So I mean, that sold it for me, Jeff. So, I did that program. And again, I think that program gave me access to a lot of people that could help me realize some of the ideas I had. So again, a lot of it is the exact same thing we were doing at Denver Health, but now I had an extended network where instead of, maybe working off a survey I created, I could now work with national data from the Association of American Medical Colleges. So again, I think there are a lot of people that can do the work. I think I was just fortunate enough to be in a position where I was given an opportunity to do it on a larger scale.
That's awesome. Well, and I got to tell you, I can't wait to see what comes next.
Thank you.
You're going to give us a preview? We're going to see what's next?
So, we actually just put out a paper on microaggressions, Jeff. So we had a national survey of medical students and their experience with microaggressions. And we found that about a third of the students, at least that we surveyed, reported experiencing at least one microaggression daily. And the reported microaggressions was associated with symptoms of depression and also students wanting to withdraw from medical school.
Wow. So what's the solution to that? I mean, there's no question pointing out a problem is the first step, but what's the solution that you can think of going forward?
Jeff, I think it's going to be tough, and I've been thinking about this a lot too, especially, with microaggressions. I think implicit in the idea is that these are in many ways subconscious. So people don't even necessarily realize they're doing it, as opposed to maybe overt discrimination. So, I don't think it's one of those situations where maybe you can just go to a training and have all those implicit biases removed. And I think in many ways, it even is maybe just a reflection of the culture we live in. So I don't know if there's maybe, I think, an individual intervention, I think it's going to be challenging. I think one area that has shown some benefit, not necessarily microaggressions, but just in people's implicit bias, is just positive social contact with people from other groups. So I think in that regards, I think it just goes back to, again, our goal of increasing diversity. So even without having an elaborate program to address people's implicit biases or prevent microaggressions, I think if we can actually just start recruiting a more diverse student body, resident body, faculty body, people will have an opportunity to interact with each other and maybe have the opportunity for some of these implicit biases to just kind of go away over time.
I do think that the pipeline is definitely key. I guess I'm curious as to what your thoughts are in terms of this idea of education being the solution to everything. And I love the idea of people being more self-aware of what their own personal biases are. But I guess my question is, do you think that actually makes a difference?
And I don't know that it does. I honestly don't know that. At least I shouldn't say no benefit by any means, but I'm not sure, like you said, I'm not sure that's going to be the solution. I think in many ways, I think we need to change just kind of our organizational structure and makeup. And again, if you walk into an environment where everyone in a senior leadership structure looks a certain way, I don't think it matters what the education you put out says. People are gonna, it's just like the hidden curriculum, right? Like we can teach certain things with professionalism or how we should treat patients, but if you see you're attending yelling at people, and that's what, how you're going to model your behavior. So I think ultimately, again, I think institutions are going to have to change and really put more emphasis on obtaining more diversity, especially at the faculty level, because I think that creates a sense of permanence, and then supporting those diverse faculty.
The retention component, I 100% agree with you. So on a slight tangent from that, you know, one of the questions that I ask each time is what makes a good doctor? What do you think it is that makes a good doctor?
So I say a few things, Jeff. I say, and I'm speaking especially from an emergency medicine perspective, but I think a relentless sense of curiosity, and I think that ultimately helps you, you know, distinguish people that actually are sick versus those that aren't, and actually, you know, not become anchored in certain, you know, biases, but, you know, truly wanting to figure out what the problem is and being curious about potential options, I think is one thing. I think another thing is, you know, just truly taking ownership of your patients as well. You know, when I remember when I was a chief resident, some of the best medical students I had were those. There's one medical student in particular. We had a patient who showed up altered, and we had no identification, no idea who this person was. And normally, you know, I think even I would just, you know, we'd work this patient up, see if we could figure out a cause to alter mental status, and ultimately that patient would get admitted, and that would be it. And I remember I had this one medical student who took care of all the medicine in that regard, all the clinical aspect, but was also very determined to socially support this patient and find out at least the next of kin, or at least a friend, someone that could help with the identification. And I remember I got an email from that medical student 2 hours after the shift ended, and she'd stayed that whole time and actually found this person's sister and was able to give a tremendous amount of history of how this change in mental status was actually very acute, literally like 2 days before the person was normal. And it completely, I think, changed the trajectory of how that patient was treated. So, you know, again, I think that combined that sense of curiosity and the sense that, you know, this medical student really felt this patient was her responsibility and was going to provide like the best care there. And then, you know, I think, and this kind of goes back to, I guess, an old cliche, but I still think treating your patients like you'd want to treat a family member. And I think anytime I see anyone, another physician I'm working with or someone in training, if they're treating the patients like they treat a family member, I think the care is going to always be exceptional.
So I hear what you're saying, and I agree with every single point that you mentioned. But I think that the other question that I have is there has to be something else besides just caring.
Yeah.
Right? There has to be something more than just like, I care a lot, because there are a lot of people that care a lot, right?
I don't know, Jeff.
I mean, I don't know what the right answer is to that, but I guess what I'm hearing you saying is that the flip side of that is pretty obvious. The people that don't care, the people that don't want to know what's going on with the patient, those are the people that are the bad doctors. I guess, would you agree with that?
I would.
But I don't know what it is. What is it that makes that like, you know, this is the doctor that I want? And I think that, you know, it's interesting that you started off by talking about it being emergency medicine specific for your answer, because I think that you're right. It probably varies pretty dramatically in terms of what makes a good radiologist.
Right.
I mean, you know, when I think of what do I want in a good radiologist, is I want somebody who's able to read films really well, and, you know, has a huge attention to detail, and has a very long differential diagnosis, and can tell me, hey, you should be worried about this and this and this and this based on this finding.
Exactly.
Whereas, you know, I guess I don't necessarily have the same focus for other people, and I don't, you know, so I think that brings up the other question that I always am wondering is what is a medical school's role in raising, that's a poor choice of words, in trying to educate our future physicians? Is it that they should be trying to educate towards each individual specialty, or is there a baseline component that medical students should know?
Right. I think that's a great point, Jeff. You know, I think I think the baseline component that I'd imagine would be fostering that sense of humanity and caring for humanity and that sense of curiosity. But I think the medical school's job beyond that is to provide a system where students will be empowered and have the ability to thrive in whatever field they find that they're going to be most passionate about. And can the school connect people to those resources, provide research opportunities, mentorship, and so forth, as related to, I guess, their growth, both as a caring physician, but then also as, an expert in whatever that specialty is.
I like that. You've talked a little bit about mentorship, and you now mentor a huge number of people yourself. I mean, you have this research team. I mean, it must be tough being a powerhouse.
No, please. I don't know about that.
But what do you see as your role as a mentor? What are you responsible for, and what are you not responsible for? I mean, I think, and I guess if you could do me a favor and contrast that with your responsibility as a parent. So Dowin has two little ones, so it's he's got a lot of personal experience from that perspective.
I think it's similar, Jeff. So, I want to provide, one, I want to identify their strengths and see if I can support them there and really allow them to flourish there. Obviously, I don't want to micromanage. So I want to, especially, with the people and my research teams, I want to kind of provide an overlying vision. And then I want to let them pretty much take care of the details to get how to get there. But at the same time, letting them know if they need anything to come to me, and I can support them in obtaining whatever resources they need to meet that goal. But I want them to feel empowered to do it, but not limited by me micromanaging them. Beyond that, and I still struggle with this, Jeff, but I do want to challenge them as well. So, and I think this is kind of the similar philosophy we had in residency. I want to challenge them, and I want them to be, to some degree, uncomfortable, because I think that's where growth happens. But obviously, I don't want to overwhelm them, and I don't want to be seen as, someone that's overbearing at the same time. So trying to figure out what that sweet spot is. And I'd be interested in knowing how you achieve that as well, in a way that, and also giving feedback, like, and most of the time, I think everyone's doing a great job, but there's still, it's my job to try to help them get further, but to do that in a way that doesn't seem overly critical, but it's supportive as well. So that's what I try to do, but I feel like I still struggle with it at times.
Well, I think it's hard. It's hard to walk that line of, being supportive, but also expecting a lot.
Right.
In fact, we were at the Academy for Diversity and Inclusion meeting. We were talking about how it is that you move people that are not normally used to being in leadership positions into leadership positions. And one of the things that we talked about was that, I mean, this sounds horrible, but essentially volunteering people, hey, you're going to do this. And, some people flourish when they get stuck in a position and they hit it out of the park, and other people don't. But I do think that if you don't push people, then they're never going to find out whether they're going to be able to do something.
Right.
And I think that it's better to figure that out early as opposed to figuring it out late, because, you don't want to waste a lot of time from that perspective. So give people the opportunity, give them the support that they need, but then, there are chances that they're not going to be able to get there, and better to find out soon.
Right. Agreed.
I will say, you talk about how it is that you tell someone that they're not doing sort of what you expect, or that you're not pushing them enough, or that sort of thing. And I think that you and I have very different communication strategies. You are much more of a, I would call it a loving communicator than I am. No, I'm being serious, right? And I am definitely much more of a blunt instrument, right? And I think that different people respond differently to different communication strategies. But I think that one of the reasons that we each have different communication strategies, and that doesn't mean that you're stuck in one and that you can only do that one for the rest of your life, but partially it's because you've seen that strategy work. And I was hoping you could talk a little bit about how you ended up with your communication strategy and why you think that is.
Yeah, I think you're right, Jeff. I think it maybe even goes back to parenting. So I would probably say that was my mother's style with me. And I felt like it was effective. And I felt like I always knew she cared and loved me, but at the same time, I knew she had high expectations. So, so in a sense, she created a system where I felt like I could thrive, and I knew that if I didn't, I could only blame myself. So yeah, I don't know. I think it's probably just watching her and see how and modeling my behavior after her.
It is amazing how much of our behavior is focused on the people that we admire, right? I mean, it's 100% true.
Absolutely.
Um, it's
Absolutely.
yeah, which is usually a positive. So my next question is tell me your favorite emergency medicine cocktail story. When somebody says, tell me an emergency medicine story, what's your go-to?
So most of them might be explicit, Jeff.
That's all right. Let me hear it.
So are you sure? Because this one's definitely, you know,
Hit
we
me.
might have. So there's this one night I was working an overnight. And I don't know if I'd been working a string of overnights or what, but I was just in a bad mood. And I walked in, and I think the first patient I saw was having flank pain. Turned out the patient had a kidney stone, and it was like a huge stone. It was like 1.2 centimeters. And I started flipping through the patient's chart, and the patient had actually been to the urology clinic 3 times that month and still hadn't had a procedure. So, the creatinine was elevated, multiple visits. So I called the urologist up and, the resident, and I'm like, this person has to come in. 1.2 centimeter stone. They've already been to your office multiple times. It's not going to pass. I think we need a stent. Creatinine's elevated. We're getting kidney failure. And the resident was just like, no, they can just follow up on Monday. And again, I was already in a bad mood. And I was like, no, this isn't happening. I was like, this patient cannot go home. This is unacceptable. So we started just kind of arguing back and forth. And then I don't know what happened. Generally, I don't lose my cool, but I just kind of like, yeah, I shouldn't say, probably didn't yell, but it was like, I raised my voice and I was like, fine, I'm just going to call your attending. And before I could hang up, the resident was like, fine, I'll come down. So the resident comes down, sees the patient, calls the attending, and of course the patient gets admitted, gets stented. So that was that. And I kind of felt bad about it after. So I was like, man, maybe I should have approached this differently, but whatever. And I just went out for the rest of my shift. And then about 4 a.m, I get a look on the board. There's a patient that comes in with like penile pain. It's the chief complaint. So I go in the room like 4 a.m. I'm like, what's going on here? So I go in the room, and there's a guy sitting with his wife, and I'm like, sir, what brings you in today? And he gives me this long, convoluted story, which makes no sense at all. I cannot figure out what's going on. At no point does he even address his penis. It's just this long story. And finally, his wife just breaks in, and she was like, you know what, doc, he just got out of prison yesterday. We hadn't seen each other in a while. We were having some pretty vigorous sex, and we heard something pop. And I was like, oh. So I was like, sir, do you mind if I take a look at your penis? So I took his penis. He clearly had, it's engorged, purple, the classic eggplant sign. So at that point, I'm like, perfect. I'm like, finally, I have a solution here. I was like, sir, I'll be right back. I'm gonna go talk to the urologist. But right when I say that, I'm like, oh crap, this is the urologist I just like yelled at like 5 hours ago. And I'm like, this is gonna be a problem because if he didn't want to come in for this guy that, was having kidney failure, there's no way he's going to want to come in at 4 a.m. for this. So I'm like pacing back and forth. I go to the vending machine, get a Coke, trying to figure out what I'm going to tell this urologist. So finally I was like, let me just call him. So I call him up and I'm like, hey, sorry to bother you at 4 a.m, but I've got this guy who just came in. He's got a broken penis. And then he responds, he was like, finally, you all have a real consult. And he like came down in like literally 30 seconds, got this guy booked the OR, and I'm like, this is what gets you. Guy with renal failure can't even get it, in the door, but this gets seen in 30 seconds. So yeah.
Wow. I mean, different strokes for different folks. So one of the things that I often tell students who are interested in emergency medicine is that that a majority of emergency medicine is not immediately saving someone's life.
Right.
It's not like on TV where you're going around and doing precordial thumps and, opening people's chests and stapling their heart shut. I mean, that's not the standard, but there are occasions where you feel like you save someone's life. Can you tell me about one of those stories?
Yeah, let me think, Jeff. Let's see here. So let's see here. Let me think about this. Those are really gratifying.
Nothing like putting you on the spot. And just so that anybody watching this knows, there's no prep for this. Dowin was like, I was like, hey, let's talk about this other thing. And then I was like, hey, you ready to do the interview? He was like, what? I haven't done any prep. I said, yeah, that's right. That's exactly how it's supposed to go.
So, I was maybe working at the VA about 2 weeks ago, Jeff, and this guy came in with shortness of breath. He kind of mentioned maybe having like a mild cough. And the main thing was he said he just felt fatigued for about maybe 2 weeks. So, it's around COVID now. So, kind of worked him up for infection. Um, I was going to do a little bit of an ACS workup as well because the gentleman was a little bit older. But the chest x-ray came back and they were like, significant cardiomegaly. So I looked through the prior chest x-rays and there was nothing. So I was like, oh, this is a little bit weird. And sure enough, he wasn't really hypotensive, but his blood pressure definitely wasn't normal. I'd say maybe like systolics in the 90s. So, I mean, technically, but not anything I'd be worried about per se. And he actually looked really good. So I was like, this is kind of strange. And I was like, let me just go take a look at his heart. So I did an echo and he had a huge pericardial effusion. So, the cardiologist came by and they put a window in. And again, he never crashed or anything, but I do feel like that could have been a situation had I been maybe in an urgent care someplace without any resources. I probably would have just sent this guy home because he looked really good and his symptoms sounded somewhat viral. But yeah, I think that was an instance recently, at least I can say maybe where there was something I wasn't expecting at all that could have been pretty deadly that we just happened to pick up.
That's awesome. That's wonderful. I do also tell students, and I don't know how true you feel this is, but I tell students that you don't know what kind of an impact you're having on patients.
Right.
And I think that's the kind of thing that you're never going to know.
Right.
And I think the Peter Rosen quote, if you're in emergency medicine, you got to get your loving at home, because rarely is it going to be the patients that tell you what a difference you're making in their life, and you gotta be okay with that.
Yeah, no, it's so true, Jeff. It's as an example. So maybe a few months ago. So my wife's a pediatrician, as you know, and she came home and she was like just really distressed. And I'm like, what's going on? And she was like, well, I had this family come in and they were just very belligerent and demanding. And I was like, oh, I'm really sorry to hear that. And then I paused and I was like, it was just one family? And she was like, yeah. And I was like, oh, get out of here. I was like, that's like every patient I see. And then sure enough, like two months after that, Jeff, I don't know, this was like during the winter. So I think she fell when she was coming up the stairs and had like, it was just a bad ankle sprain, but she was like really worried about it. And I was actually working that night anyway. So I was like, why don't you just come in? We can hang out for a little bit and, can x-ray your ankle. So she comes in and there's like this little urgent care area that's really just kind of like a wall along the main ED. So they bring her over to my side and she's kind of at that wall. So I get a little break. So I go sit with her and we're just waiting on her x-ray to come back. And this patient comes out of his room and he walks up to the nurse's desk and literally points at everyone and was like, fuck you, fuck you, fuck you. And then just walks out. And my wife's looking at me. She's like, does this happen every day? I was like, this is
this is normal. Exactly.
It's like no one was even fazed by that person.
Oh, that is one of the things about emergency medicine. You're always going to come home with some good story. That's the way that it always goes. Yeah. No, I love that. I love that. So, one of the other things that always comes up is the idea of work-life balance and how exactly it is that you make that transition, and how it is that you are able to do all the stuff that you do while still being, a good parent and a good husband and that sort of thing. And I think that everyone has a different way of doing it. How do you do it?
So first I'd have to admit, I don't think I'm good at it, Jeff. So just to lay that out there, but I think what would maybe separate me from someone who's just terrible at it is I am trying to get better. So I am learning things over time. So I think the first thing was just setting clear boundaries. And I think this is something I learned from you too, Jeff, in terms of like, when you're at home, you should just be at home. And when I was a resident, I didn't feel like I could do that just because, your schedule's very demanding. There's a certain amount of information you need to learn to, be excellent by the time you leave. But when I started fellowship, I was working a lot less shifts, and I did make a conscious effort to, if I could avoid it, not to do work at home. That's obviously changed now because, you know, I spend all my time at home, but but before I really would try, unless I had like a really pressing deadline, to just do all my work at work, and then if I was home, just be home with the family and the kids. And then I think Rainey began to appreciate that. I remember we actually, my first year as a fellow, we actually did have an argument, and she was like, "You don't spend enough time at home." I'm like, "What are you talking about?" I was like, "Look at these hours that I've changed." And she was like, "Oh, I didn't realize it because you were just gone so much during residency." So, you know, I think to that point, even though I thought I couldn't do it in residency, it's probably best to start doing that as early as possible, just so, you know, everyone still feels valued. The other thing that we recently started doing, I want to say about 2 years ago, that's been tremendously helpful, is just getting as much outside help as possible. So we have someone that helps with the kids now, that's essentially full time. That's been tremendous, because before I felt like I would spend an hour to two every day just going to pick up the kids. We'd never have dinner, so we're always picking up fast food, and it was just a disaster. And now there's like a lot more stability, that we have additional help. So I think investing as much help is beneficial, just right up from the beginning. And then probably the last thing is just, I remember there's this happiness course that I took at Yale recently. I think you heard about it too, Jeff, right? It was like,
Yeah, she's super famous, and in fact, it's a MOOC now. It's a, you know, massive open online course. Yeah.
yes, yes, exactly. So I took that course, and that course was great. And one of the things it talked about was really just how, you know, we're driven to work so much. And I mean, obviously, there's a certain amount we have to do, but I think it's kind of maybe ingrained in our culture that we have to do more and more and more. And she had all these studies about how working those extra hours never brought anyone happiness. Even getting those additional promotions never brought any happiness. And then she ended it with a quote like, "No one's on their deathbed wishing they worked more." So I was like, you know, I think that's true too. So I think now I before I do something new in terms of work, I try to balance it with, would I rather be spending time with my family? And the odds are I probably would, but there's this like pressure to do the work. And then two, if I am choosing to work, is it really like a once in a lifetime opportunity that I be upset with myself with otherwise? And if it doesn't meet those two criteria, then I just won't do it.
Move on. So I was listening to a TED talk, and it had two people on it. One of them was AJ Jacobs, who's the guy that wrote this book where he literally thanked every person that was involved in making his cup of coffee.
Oh,
So
well,
like, you know, he like thanked the logo designers for the coffee cup, and he thanked the people that make the cups, and the people that make the, you know, the people that grow the beans, and you know, it took him a year to do all this. And he was talking about it, and was talking about the whole idea of gratitude.
right,
And then right after that was a Benedictine monk who was talking about something similar, and basically said the people that are happy are the grateful people, but the people that are grateful are not. I'm sorry, the people that are, is that right? The people that are grateful are happy, but the people that are happy are not always grateful.
yeah,
Saying that essentially gratefulness is what ends up making you happy, which I thought was an interesting perspective. But then on the flip side, one of the discussion points was that if you want to be happy, you don't have any goals. If you're satisfied with what you got, then you're more likely to be happy. And I think that that's one of these sort of big problems that I have is, you know, if you want to tell somebody, well, you know, happiness is your goal, then are you also telling them you shouldn't try and achieve anything?
right.
And so, you know, where do you fall in that balance? And you know, obviously you've achieved a ton. And so I think that by definition, there has to be a component of you that's not satisfied. It's not like, hey, this is okay, that you want to do more and you want to do more. And that's that pull from the other side.
Right.
But you know, it's how you balance those two sides of being satisfied and wanting more, and where exactly you fall with that, and where the gratefulness falls along with that.
Right. No, I think that's key, Jeff. I think that's key. And I think one of the things I try to do now when it's related to work is it work I'm really passionate about, or is it work I think I have to do because I'm going to get judged if I don't do it? And if it's work I'm passionate about, the odds are if I do it and I'm spending time away from the family, at least I'll still be happy with the work. Whereas I feel like a lot of times I try to say no more, but it's still hard. But sometimes you're like, why am I doing this? It's taking up my whole day. I'm not enjoying it. I'm not spending time with family. And then I feel like that's when I'm really not happy. So I think as much as possible, and it probably is a luxury, but as much as possible in terms of linking our work to what we're really passionate about, I think will help us be happy.
I love that. I love that. So when you're advising a student or one of the people on your research team and they're talking to you about another job or a specialty choice or something like that, how do you tell them to make those choices? How do you tell them to evaluate components?
Right. I was actually speaking with one of my mentees about this in terms of a summer program. He's first year, he's about to finish his first year of medical school now. And he had 3 programs he was interested in. And then at one point he actually there are 2 he was really excited about. And he felt like with COVID now he had the opportunity to do both. And I was like, no. It's like
At the same
at
time.
the same
Wow.
time. And I was like, you might be able to pull this out, but I can see there's going to be a point where you're going to have a meeting at both places. It's going to be via Zoom, and you're going to be like looking at one screen here and trying to talk to someone else. And I was like, I was like, at this point, I think again, he was feeling that pressure that he needs to put something. Well, one, he did like both of these, so give him that. But there was also this pressure that he wanted to put something on his resume to be competitive for residency. And as I'm sure you're aware, Jeff, every year I think there's this identity that gets more and more competitive, right? So I told him, this is going to be your last summer. I think it's great that you're doing something this summer. Do one thing you care about and do that really well, and then enjoy the rest of your time. Otherwise, you're going to burn out or just put yourself in a compromised position. So I think it's the same thing, Jeff. I think I try to tell people to try to maximize this ratio of doing what you care about, and then at the same time, I don't want to say doing as little as possible, but just maximizing that ratio. If you can do one thing that's amazing, it's a lot better than 2 or 3 things that are just okay.
So every single one of us has made mistakes in life.
Yeah.
Every single one of us. I mean, none of us are perfect. What's the biggest mistake that you wish you could take back? Or what's the biggest thing if you could go back and, I guess, depending on how you want to see it, either tell yourself or tell your kids to not make the same mistake, what would you say?
So this is going to sound ridiculous, Jeff. I think this gets back to what we were talking about before. So when I was, I guess, an intern in residency, I set up an elective in Argentina. And this was during a point where I thought I really wanted to do global health. Like I was super gung-ho about global health, even though I don't do any global health now. So, so I set up this elective in Argentina, and I thought it was like the most important thing ever. And I thought it was gonna be like extremely important for my future. So I went on this elective, but, and this sounds ridiculous, my son was born maybe 6 months before that. And my wife did not want me to go on this elective. And in retrospect, I should not have gone this, but it was a situation again where in my mind, I was choosing work over the family, and it created a huge amount of tension that I think to this day, my wife is still angry that I went on that trip.
And it turns out the trip didn't really matter that much long term.
Right, right.
Yeah, but
So,
you didn't know that in the time.
right. And again, I think it goes back to this idea in terms of that work-life balance that you're talking about, Jeff. I think, and again, I'm still learning this and I'm still trying to get better at it. But I think what I'm definitely learning now is when people at home aren't happy, I'm not happy at work. So yeah. So I guess that's, yeah.
You got to figure it out. No, I love that. I love that.
So
Well, we are running towards the end of our time, but I did want to give you the opportunity to anything else that you need to tell me, anything else that I should know about thoughts or visions for the future, or a story from the past, something else that I need to know.
let me see here. So there's one story from the past that I still think about often. So I remember when we first at that breakfast, we talked about starting a diversity committee. And one of the first things we did, of course, we came up with a strategic plan. And I remember we had a budget. And I think there are two things that kind of stick out. I remember for the budget, I forget what I had originally, but I think it was maybe around like $3,000 or $4,000. And we showed this budget to Renee King, and Renee was like, "No, you gotta at least like triple this budget." And I didn't think we'd even get the $3,000 or $4,000, but I was like, "Okay, Renee." So I think we bumped the budget up to maybe like 12,000, something along those lines. And we go and present this budget to the chair, and the chair was Rich Zane. And at the end of the presentation, I remember Rich looking at us and saying, "This is just going to be the tip of the iceberg." And I had no idea what that meant. And I looked at you, and then you looked at Rich, and you're like, "So does this mean we're getting the money or not?"
Yeah.
And yeah.
And we did get the money. I mean, he gave us the
it.
money. Yeah.
Got it. Yeah. And it was just the tip of the iceberg, because in the future years we got even more. But
what's the moral of that story? What's the punchline that we should take away from that?
I think a couple of things. I think I liked Renee's comment in the sense of just be as bold as possible, because the worst thing he could do is say no, and it wouldn't matter what our number was. He probably would have said no regardless if he didn't want to do it. And then, so I guess in that sense, I think Renee, pushing us to be bold, I think was great. And then us not negotiating against ourselves was great too, in the sense that, we did present a very ambitious plan. I think the other thing is, I think if you're trying to do something different and maybe be a disruptor, I think you have to be as bold as possible, because I think it's hard enough to get any change, even when you're being aggressive. But if you come with a tepid plan, then definitely nothing's going to happen. And then I think what I love about your statement too, Jeff, at the end, it was just like, bottom line, are we doing this or not? I think that's also what I think that's ultimately what all these conversations are about, right? I think both sides might have apprehensions. I think I was a little bit anxious when we were doing that presentation, but ultimately it's just going to be everything you just need to present yes, no decisions to people to promote change.
I love it. Well, I do want to end on a specific note. We've talked a little bit about gratitude, and I want to express my deep gratitude to you.
Well, thank you, Jeff.
Because honestly, you have been an amazing influence on my life. You've dramatically influenced my career, and I don't know if I've ever told you that, but you have been an absolute shining star for me, and I really appreciate everything you've done for me.
Well, thank you, Jeff. And Jeff, thank you. You've been the best mentor I could possibly have.
I don't know if that's true, but honestly, I can't wait for us to be done with COVID, and so I get to see you in person again.
Likewise. Where's SAM is going to be in New Orleans next year?
It is. I have a good feeling about that.
That's going to be awesome. All right. Well, hopefully I can see you even before then. But
I love that. That sounds awesome. All right. Well, thanks, Dowin. I'll talk to you later.
Talk to you soon.
Bye.